Welcome to NCLEX RN Review, produced by Nursing Tutorial and Consulting Services. This session is entitled Essential Concepts 2. I'm Judith Miller, and I will be your guide as we go through this session. The first thing that we're going to talk about in this session is fluids and electrolytes, and then we'll lead into acid-base and go on to some other concepts. So let's start talking about fluid and electrolyte balance. When we talk about fluids and electrolytes, if you look at this picture, you note all those numbers there. The good news is you don't have to memorize all of those numbers. The important concept is that noting that those that are very old are half dehydrated to start with, and that the babies are all water to start with. So the people that get into fluid imbalances most quickly are the very old that are half dehydrated and the very young that are supposed to be all water. I don't think they're going to ask you a question that says what percent of an adult male's body weight is water. It's about 2/3, but they aren't going to ask you that. But they might ask you which patient would get into fluid imbalance more quickly. If you had a 20-year-old with 3 days of vomiting and diarrhea, or a 6-month-old with 3 days of vomiting and diarrhea, it's going to be the 6-month-old. Now, another concept related to that has to do with the fact that the fluid that's in your body is in different places. Most of it is within the cells. It is intracellular. Now, we don't actually pull cells apart and say how much water is inside your cell. But about 70% of the fluid in your body is inside cells. That means the other 30% is extracellular, and of that it's in two major compartments. We see most of it in the interstitial tissues. About 24% is in the interstitial, between cells, between tissues. And that small compartment, 6% of it, is in your bloodstream. Now, of all of those compartments, the one that's most susceptible to imbalance is the smallest one, the bloodstream. And so that's quite susceptible to fluid imbalances. Again, I don't think you need to remember the exact numbers with that, but note that it's in different compartments, and actually fluids and electrolytes can move from one compartment to another. So let's talk a bit about how they move from one place to another. And the electrolytes we mentioned move as well. So before we look at their movement, how they move, let's talk about the numbers. You want to memorize numbers? Memorize these. These are in milliequivalents per liter, and these are ones that you need to memorize. You should know the norms. Serum sodium is roughly 135 to 145 milliequivalents per liter. Serum potassium, 3.5 to 5.5, 5 point something, somewhere between 5.0 and 5.5 milliequivalents per liter. Now, some of you may have memorized numbers slightly different. If you were to pick up 5 laboratory handbooks, you would probably have at least 4 sets of different numbers. And people who write the exams know that. So they are going to give you something that's clearly high or clearly no, not low, not something that is terribly borderline with that. Now, the serum chloride levels are roughly 85 to 115. These are probably the least important ones to memorize because they usually follow the sodium or potassium levels. And bicarb, 22 to 27. Now, we're also going to look at bicarb when we talk about blood gases in a few minutes. But the serum sodium and serum potassium you have to know. So put these on your list and memorize them. Now I'm going to look at the intracellular numbers. You're not going to be asked about those on the exam, but the concepts are important for us to know. Notice that sodium is high in the bloodstream and low in the cell, whereas potassium is high in the cell and low in the bloodstream. This is important for us. For instance, if your serum potassium was extremely high, one of the things you might do to lower it would be to give insulin and glucose IV to try and push it back into the cell. Think in terms of what would happen if your patient has serious cellular damage. So they have major injuries or they have burns. As those cells are damaged, they open up and the potassium comes flowing out and you get hyperkalemia. So those are just important things to remember. It's not necessary to memorize the intracellular numbers, but I would know that sodium is high in the bloodstream, low in the cell, and potassium is the opposite. Low in the bloodstream, high in the cell. Now, how do fluids and electrolytes move from one place to another? Diffusion, you learned in school, was the movement of particles from an area of higher concentration to one of lower concentration across a semi-permeable membrane. So if you look at that picture, you'll note that there's little tiny dots there. And you see the arrow, they move across the semi-permeable membrane to an area where there's not very many dots. This is what happens to electrolytes. So if there were a lot of electrolytes on one side of that semi-permeable membrane, they would tend to cross it to the area that is lower concentration. And this is diffusion. Now let's talk a little bit about osmosis. Osmosis is the movement of fluid from an area of lower concentration to one of higher concentration, again across that semi-permeable membrane. If you'll notice at the picture with osmosis that those are great big circles. Think of those as albumin. And what happens is that albumin is too big to cross that semi-permeable membrane, so it pulls the fluid across. It sucks fluid across. It acts like a sponge and sucks it up and pulls it across. So osmosis is the movement of fluid from lower to higher concentration across a semi-permeable membrane. And it's caused primarily by albumin in the bloodstream. Other things that could cause osmosis are high concentrations of glucose, for instance. Let's do a question about this. The nurse is caring for a client who has a nasogastric tube attached to intermittent suction. The client frequently asks for ice chips. The nurse gives ice chips sparingly. For which reason? 1. Too much fluid may cause nausea and vomiting. 2. Hypotonic solutions cause electrolyte dilution. 3. Cold liquids cause gas. Or 4. Fluids in the stomach may overload the suction system. So the correct answer is number 2. Now let's talk about that. The client asked for ice chips. So ice chips are made out of water, tap water, which is hypotonic. The ice chips melt, they're swallowed, and we get diffusion, the movement of electrolytes across the semi-permeable membrane into that hypotonic solution. Then the suction machine comes on and sucks those electrolytes out, and you end up with a jar full of electrolytes, and the patient develops hyponatremia, hypokalemia, hypochloremia. Let's look at another question. The nurse is caring for a client who has cirrhosis of the liver. Salt-poor albumin is ordered. Which nursing assessment indicates the albumin is having the desired effect? Number 1, the urine output decreases to 30 milliliters an hour. Number 2, abdominal girth decreases. Number 3, weight is 1 pound more than yesterday. And number 4, temperature is normal. And the correct answer here is number 2, abdominal girth decreases. Look at the data in the question. The patient has cirrhosis of the liver, and he's given albumin. Now, patients with cirrhosis of the liver have ascites. So they have an enlarged abdomen with fluid in the abdomen. One of the reasons they have ascites is they don't have enough albumin in their system. We'll talk about some other reasons on another session. but they don't have enough albumin in their system because it's the liver that makes albumin, and they have a sick liver. So if you give the patient albumin IV, it will pull fluid in the bloodstream, reduce the ascites, reduce the edema in the abdomen, and you will actually be measuring that abdominal girth at least every shift, sometimes more frequently. Now the urine output would increase because they're going to urinate off the urine. The weight would go down because water weighs, and when you get rid of it, you weigh less. Temperature is not a factor here. Now this is an osmosis question, although the word osmosis was never mentioned. And the previous question was a diffusion question. Again, the word diffusion was never mentioned. Now they're likely to give you questions like this on the exam rather than asking you the definitions of diffusion and osmosis. They might also ask you about, let's say you are to give, a patient is to receive irrigations, wound irrigations. What substance is most likely to be used for the wound irrigation? And the answer is normal saline, because it is isotonic and would not cause a movement of fluids or electrolytes. If you had to give a patient an enema every day, what solution would you use? Normal saline. Again, if you had to do it daily, that would cause the least fluid and electrolyte shifting. Now, when we talk about types of solution, iso means same. So isotonic solutions have the same tonicity as body fluids. Isotonic solutions tend to stay put. Sometimes I say they neither give nor receive. Examples of isotonic solutions would include normal saline, and that's 0.9% saline. D5W starts out as isotonic but becomes slightly hypotonic as the glucose is used up. Ringer's lactate or lactated Ringer's solutions are isotonic as well. Now, when the patient receives a hypotonic solution, hypotonic means it has less tonicity than body fluids. This is anything like tap water, any kind of saline solution less than 0.9%, so like 0.45, which is half normal, or 0.33, which is third normal. Hypotonic solution hydrates cells. It can also cause an electrolyte dilution, as we saw in that question a few moments ago. Hypertonic solutions have a tonicity that is greater than body fluids. These are solutions such as D10%, anything higher than dextrose 5% in water. Albumin. Remember the question we did a few minutes ago where we had albumin that pulled fluid into the bloodstream. Hypertonic solutions expand volume, so they pull their fluid into the bloodstream. Now, as we continue to talk about fluid balance, mechanisms of fluid balance, the kidneys, the lungs, and the skin are the main organs that regulate fluid balance. There are two hormones that are absolutely essential to fluid balance. Antidiuretic hormone, which is actually made in the hypothalamus and stored and secreted by the posterior pituitary. And this says to the kidney, hold on to sodium and water. And we also need to think about aldosterone. Aldosterone is made in the adrenal cortex and says to the kidney, hold on to sodium and water and get rid of potassium. So it regulates not only sodium and water balance, but also potassium balance. These two hormones are very important, and we'll be talking about them frequently as we go through the different sessions. Now, if we take a look at the sources of fluid and the losses of fluid every day, you don't have to memorize the whole page here, but you do need to know that what goes in equals what goes out on the average. And when you take in fluid, it's not only the water that you take in, but there's fluid in your food. For instance, which has more water, crackers or apples? Obviously, it's apples. Fruits and vegetables have more water than your things like breads and cereals do. There's also a little bit of water that's made each day through metabolic oxidation. When people are on a very strict intake and output, such as someone in renal failure, we have to account for those metabolic oxidation fluids as well. Now, if we look at fluid losses, we know that we lose fluid through the urine, feces, skin, perspiration, lungs. Now, as you're sitting quietly in a room, the room may be a comfortable temperature, but you are still losing fluid through your skin. If it were extremely hot out, you would lose even more fluid through perspiration. Every breath that you take, you're breathing out water. Every breath you breathe out water as well as carbon dioxide. I might ask you, what is the normal hourly output of urine? And most of you are probably thinking, or at least some of you are thinking 30 milliliters per hour, and that's not the right answer. 30 milliliters an hour is the minimum for an adult. Below that, we talk about the patient being in shock. Double it for the normal value, 60. Actually, somewhere between 50 and 70 milliliters an hour is pretty normal for an adult. Your 24-hour output is more likely to be closer to 1,500 milliliters, give or take a little bit. Now, it will depend upon how much you're taking in, how much you put out, the weather, etc. But I would know that 1,500 milliliters or 50, 60 milliliters an hour is the normal urine output. Now, if we look at losses, you don't have to memorize this entire slide here. What you need to know is that if a patient has a fever, their fluid losses increase. So what would you do for people with fevers? You would hydrate them. If a patient is exercising vigorously, their fluid loss increases. So what would you teach people to do if they're exercising a lot? Hydrate, drink fluids. And that's probably enough to recall from that. Now I want us to talk a little bit about fluid balance. We want to talk about dehydration. Now when we think about dehydration, the causes of dehydration, you're losing more than you're taking in. So people can get dehydrated with excessive vomiting and diarrhea. They could also get dehydrated if they don't take in enough fluids, whether it's PO fluids or even not enough IV fluid replacement. And I suspect that you know the symptoms of dehydration. You know the dry, warm skin and the poor skin turgor. And you would know that the urine would be usually decreased in amount and rather concentrated, so it's dark and foul-smelling or odorous urine. Patients lose weight when they are dehydrated. And obviously then, what do we do for a dehydrated patient? We hydrate them. And so hydration is a key element in the management of their care. Let's look at a question. An elderly woman is admitted with dehydration. How can the nurse best evaluate the effectiveness of fluid restoration treatment? Number 1, obtain weights daily. 2, assess skin turgor daily. 3, monitor temperature every shift. Or 4, take vital signs 4 times a day. So to monitor the effectiveness of fluid restoration treatment, the best answer is number 1. Now there's a little bit of truth to answer number 2. Skin turgor gives you some clue about dehydration. But look at the patient. This patient is an elderly patient. What's the skin turgor in elderly patients? It is poor to start with. So the best way to tell you whether you're restoring the fluid or not in this patient, as actually in all patients, is going to be daily weights. Now if we look at the opposite problem, Circulatory overload is extracellular fluid volume excess. And the problem is too many fluids, too fast, or the heart and or kidneys are not working effectively. So it's either too many fluids too fast and or the heart and kidneys are not particularly effective. This can occur in anybody, but it occurs faster in older people where their body systems are not as efficient as those of younger people. Now, if you look at the symptoms, I'm sure you're familiar with the tachycardia, flushed skin. Both arterial and venous pressure rise, so you get neck vein distension, increase in central venous pressure, as well as an increase in arterial blood pressure. Then you get the pulmonary symptoms, so you get tachypnea, and then you get fluid in the lungs, so a cough and dyspnea, and sometimes full-blown pulmonary edema with the whole pink frothy sputum piece. So a question. The nurse is caring for a client who is in fluid overload. Which medication does the nurse expect to be ordered for this client? Furosemide, lidocaine, penicillin, or propranolol? And I can almost hear you telling me, oh, furosemide. Yes, that's correct. Furosemide or Lasix is a diuretic. Now, what kind of a drug is lidocaine? Lidocaine can be either an antiarrhythmic or a local anesthetic. And penicillin is an antibiotic, and propranolol is a beta blocker. Whenever you see drug questions like this, you want to ask yourself what the other drugs do. Even though you know the correct answer, ask yourself what the other drugs do. Now, circulatory overload or extracellular fluid volume excess, we said you're going to have to give diuretics. We just did a question about that. You may also need to do fluid restrictions until the situation is under control. If the problem is caused by heart failure, if it's cardiac related, the patient might also be on digoxin, but only if it's a cardiac related. Now I want to take a look at some electrolytes, and the two I want to talk about right now are potassium and sodium. So when we think about potassium imbalances, we start first by saying, what does potassium do? Potassium plays a role in neuromuscular activity. And don't forget, the heart's a muscle. So the symptoms that we see with imbalances in potassium are going to be muscle weakness and cardiac dysrhythmias. Potassium also plays a role in acid-base balance. When a patient is acidotic, the serum potassium level rises. So acidosis tends to cause hyperkalemia. You also need to know another factor too about potassium to answer questions about it, and that is that 80% of the potassium that is excreted every day goes out through the kidneys. The other 20% goes out through the GI tract. So knowing that piece of information, you can ask yourself, or I can ask you, what is the most common cause of hyperkalemia? And the answer to that is renal failure. If most of the potassium goes out through your kidneys, then the cause of hyperkalemia would be renal failure. We could turn it around and say, what's the most common cause of hypokalemia? And the answer would be diuretics, which cause the loss of potassium along with the fluid. Now, you could also get hypokalemia with things like diarrhea and vomiting, where you have excess fluid, GI tract fluid losses. Now, let's take a look at sodium. Sodium is in all body fluids. Where goes sodium, there goes water. So it plays a major role in fluid balance. It plays a role in acid-base balance and also nerve conduction. And I'm going to share a story with you about sodium and hyponatremia. I one time asked some students if they'd ever seen a patient in hyponatremia. And one young man told me, yes, indeed, he had. And he told me that he would describe the patient as being pleasantly confused. So I asked him for a few more details about it, and he told me this incident. He said that this patient was hyponatremic, and so on her tray was broth and high salty foods. And she had been told when her tray came up for lunch, eat everything. They just told her, eat everything. And he walked in the room just as she was starting to munch on a bar of soap. Now the soap dish had been left there for morning care, and she was so confused that she didn't know the difference between food and soap. So now whenever I think of hyponatremia, I think of that poor soap dish lady with her mental confusion. And I recognize that as a sign of hyponatremia. And when I think of hypernatremia, I think about going to the Chinese restaurant where there's a lot of sodium in your food. And you note that sometimes your mouth gets kind of dry and sticky in those mucous membranes. It's kind of thick, sticky. And you do very appropriate things. You drink a lot of fluid. But even so, when you get home, you notice that your rings are a little tight. But you're very smart nurses. You drink a lot of water. You may have to get up sometimes at night to go to the bathroom. But the next day, everything is back to normal again, and you're back in fluid balance. And it was well worth it because the food tasted so good. So when I think of hyponatremia, I think of that poor soap dish lady. And when I think of hypernatremia, I think of going to the Chinese restaurant. Now let's do some questions. An adult who is in renal failure has a serum potassium of 7.3 milliequivalents per liter. A Kayexalate is ordered for him for which reason? Number 1, to remove fluid from the extracellular spaces. Number 2, to exchange sodium for potassium. Number 3, to reduce abdominal pressure. And number 4, to introduce potassium into the bowel to combat hypokalemia. Now, as we go to evaluate this question, I want you to look at the data in the question. The patient has a serum potassium of 7.3. That's going to eliminate answer number 4, isn't it? It says to combat hypokalemia. And if you know the normal serum potassium is 3.5 to 5.5 or so, then you know this patient is not hypokalemic. They are hyperkalemic. So you can eliminate 4. Now, the correct answer for this one is number 2. The Kayexalate enema is a sodium-potassium exchange resin. And when it's given as an enema form, it's a 6-hour retention enema. That's right, 6 hours. It's a very small amount and is to be retained for 6 hours, and it exchanges sodium ions for potassium ions and reduces the serum potassium when it is dangerously high. We can also give Kayexalate as an oral preparation, and sometimes it's administered that way. Another question for us. An elderly woman is admitted to the medical unit. Which observation by the nurse is most suggestive of an alteration in the serum sodium level? Number 1, muscle weakness. 2, irregular pulse. 3, mental confusion. And 4, hyperreflexia. So an alteration in the serum sodium level, you're all going to get this one correct. It's number 3, mental confusion. Remember that soap dish lady that we talked about. Now, choice number 1, muscle weakness, would be more appropriate with which electrolyte problem? Potassium. Irregular pulse would also be typical of a potassium alteration. And number 4, hyperreflexia, would be more typical of a calcium, hypocalcemia. We haven't talked about that yet, but we would see that with hypocalcemia. Another question for us. The nurse is caring for a client who has a serum potassium of 7.5 milliequivalents per liter. For which of these emergencies should the nurse be prepared? Number 1, cardiac arrest. 2, pulmonary edema. 3, circulatory collapse, or 4, recurring hemorrhaging? And the answer, of course, is number 1, cardiac arrest. An elderly man has a nasogastric tube attached to intermittent suction. He has an IV running with potassium chloride added. The nurse knows that potassium is administered to, number 1, replace potassium being lost in the urine. 2, replace the potassium that is lost in the gastric drainage. 3, restore the potassium level that elderly clients cannot achieve in their diets. Or 4, provide potassium that will decrease the amount of sodium. Now, if we take a look at that, the problem is he has an NG tube to intermittent suction. The answer has to relate to that, so the answer is number 2. Replace the potassium that is lost in the gastric drainage. We're going to look at a similar question. An elderly client is admitted with congestive heart failure. He is receiving digoxin and furosemide. He has an IV running with potassium chloride added. The nurse knows the potassium is administered too. And we actually have the same choices we had in the last question. Replace potassium being lost in the urine. Replace the potassium that is lost in the gastric drainage. Restore the potassium level that elderly clients cannot achieve in their diets. Or provide potassium that will decrease the amount of sodium. Now, in this one, we have a different problem, so we have a different answer. This patient was receiving Lasix, and the answer then is number 1. Replace potassium being lost in the urine, because Lasix is a potassium-depleting diuretic. The next thing we want to do is talk a little bit about some of the IV fluids. And the first thing I want to do is ask you a question. How many calories in a liter of D5W? Well, if you want the answer, you can take a look at the screen and notice that it says there are 200 calories in a liter of D5W. You could actually figure it out. You could say that if a liter is 5% dextrose, which is glucose, there's about 50 grams of glucose, and there's 4 calories per gram for carbohydrates, so that's roughly 200 calories per liter. That's not very many. And usually when we give IV solutions, we don't give 3 liters of D5W because the patient needs electrolytes. So we just simply are not giving patients very many fluids when they're only on IV fluids. How many calories in a liter of normal saline? That's right, none. Salt doesn't have calories, and neither does fluid. How many calories in a liter of ringers? None. The electrolytes don't have calories, and neither do the fluids. So when we give patients only IV fluids, we're not giving very many calories. Now on your picture on your screen, it also shows about albumin. We talked about those. Those are plasma expanders. They pull fluid into the bloodstream. Those are your hypertonic solutions. Let's do a question about some IVs here. The client's IV is not dripping. Which findings suggest the IV has infiltrated? Number 1, the area around the needle is red and warm. Number 2, the area around the needle is cool and blanched. Number 3, the vein is red streaked. Or number 4, the IV starts to drip when the nurse moves the client's arm. So the question asks us which suggests infiltration. Now, did you notice that answers 1 and 2 are opposite? So the answer is probably either one of those 2. And it is. The answer is number 2. Infiltration causes the area around the needle to be cool and blanched. When that IV fluid, that room temperature IV fluid, is infiltrating and causing vasoconstriction, you're going to have cool, blanched. Red and warm suggests phlebitis. Did you also note that 1 and 3 are very similar? They both talk about being red. Those answers are too much alike. You could probably eliminate those two. Now, answer number 4 says the IV starts to drip when the nurse moves the client's arm. As we look at the next picture, I want you to note in here which one of these needles, this represents a vein, the red lines are a vein, and the little arrowed lines are needles in the vein. So which one of these, if you change the client's position, is more likely to drip better? And the answer is number C. That's near the edge of the vein. Changing the patient's position, the arm position, even slightly moving the needle, it would probably drip better. Now, which one of these represents infiltration as we had in the prior question? That's right, number A is infiltration. That means that needle is out of the vein and the fluid is going into the tissue. And B in this picture represents a clot at the end of the needle. It is much better to aspirate a clot than it would be to flush a clot. If a patient has a clot at the end of the needle and you flush it, you've set a clot loose in their veins. It doesn't usually happen, but conceivably this patient could get a pulmonary embolism as a result of that clot. So aspiration is good, flushing is not. When you flush an IV line, you are preventing clots. You are not trying to get rid of them. Another question for us. An adult is receiving an IV infusion. 1/2 hour after starting the second liter, the client's temperature rises to 103 Fahrenheit. The client complains of chills, headache, backache, general malaise, and is vomiting. What is the best interpretation of these data? Number 1, the IV has infiltrated. Number 2, the client is having an anaphylactic reaction. Number 3, the tubing or IV solution may be contaminated. And number 4, the client's underlying condition is getting worse. Now, looking at that data, the best interpretation of the data has got to be number 3. This would suggest that there's a contamination of the IV solution. Note the time factor. This started 1/2 hour after starting the second liter. So it relates it very specifically to something wrong with that second liter. The symptoms do not suggest infiltration or anaphylactic reaction, and we don't have any idea what his underlying condition is. Anaphylaxis, if you have a fever, it would be a very low-grade fever, but the major symptoms would be dyspnea, hypotension, not the high fever and the headache and backache. Another question for us. The nurse enters an adult's room and notes the client appears to be in distress. The IV has been running for 7 hours and the bottle has run dry. The client appears shocky. What is the most likely explanation for the client's symptoms? Choice number 1, an air embolism. Number 2, too rapid infusion of fluids. Number 3, circulatory overload. And number 4, bacteremia. Now, as we go to look at the answers and select our choice, notice that answers number 2 and 3 say essentially the same thing. You can eliminate those 2 answers. Bacteremia would have a fever, so it's not that one. The correct answer is number 1, an air embolism. Now, does it matter that the question says the bottle has run dry? Yes, it does. It's been running for 7 hours. That would also eliminate the overload piece. But 7 hours and it has run dry, and it is a bottle, not a bag. Bags collapse. So if a bag runs dry, there's very little danger of an air embolism. But a glass bottles don't collapse. So you have to have an air vent into a glass bottle. And that allows air to enter into that system. So if a bottle runs dry, there's a very real risk of an air embolism, but not when it's a bag. So that key word in the question of the bottle running dry was a very important word for us. Now you might say, come on, we use only bags. That's not true. We use mostly bags. We use plastic bags a lot. But there are many drugs that are incompatible with plastics and must be given in bottles. So you could see a question that related to a bottle. Another issue with these fluids that I want us to look at is central venous lines. There are some specific nursing care measures associated with this that you should be comfortable with. One, this is flush daily with saline or heparin. Now the flushing is to prevent clots from forming. It's not to get rid of them and push them out in the circulation. It's to prevent clots from forming. Studies have taught us that saline is just about as effective at preventing clots from forming as heparin. And many hospitals now are using saline flushes rather than heparin flushes. Saline is cheaper. When a patient has a central venous line, dressings are changed usually 3 times a week or every other day. Infection is your biggest concern because this line goes right to the heart, right to the right atrium. You should discard 5 or 10 milliliters of fluid when withdrawing blood. Use the port for its designated purpose. If you have a multi-lumen line, so you've got a double or a triple lumen catheter, you only use the port for IV fluids or is used for fluids. The port for feeding is used for feeding. If you're going to do blood draws, that's used for blood draws. You use it only for the purpose for which it was designated. You don't draw bloods from a feeding line. You don't give medications in the feeding port. One other thing I know they've asked about, and that is that when you're removing or changing the tubing of most central lines, you want the patient to take a deep breath and hold it, Valsalva's maneuver. The purpose of this is so that air won't be drawn into the system. So if you have that tubing open when you're changing or removing a line, have the patient take a deep breath and hold it. And that way you would reduce the likelihood of any type